where we were interested in keeping everyone updated. So this is a series of 3 updates, and this is the second one. I'm Rodney Pearce. I'm a practicing GP in Adelaide and the current chair of the Immunisation Coalition. In the spirit of reconciliation, the Immunisation Coalition acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. And we pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people who are on this call. The objective, as I said, of this webinar, we are here tonight as a multidisciplinary group to discuss flu, COVID-19, RSV, and the impact they're having on our community. As we talk about each of these infectious diseases, we hope to share information across general practice, hospitals, pharmacy in the community, and try to achieve vaccine updates. We aim to keep each service abreast with key activities and initiatives planned leading into the winter season, which is a little delayed, and help minimise the effects of COVID-19 and RSV infections. Share strategies and tactics within our own services that align with government initiatives to help increase vaccination rates. And we'll have an update to see what's tracking in the respiratory season, to look at various activities that are happening around the country that we believe are helping to increase vaccination rates and maybe wondering why they're not what we're expecting, and whether there's anything we've learned from last year and earlier this year that might actually help us over the next couple of months. So to join me and help me with this is firstly the 3 experts in their field. So I've got firstly Professor Paul Griffin, an infectious disease physician and clinical microbiologist, joining us from maybe the warm weather up north, from Mater Health Services and head of Mater Clinical Unit at the University of Queensland School of Medicine. He's an accomplished clinical trial investigator. He's fulfilled the role of principal investigator in over 150 clinical trials, particularly in infectious diseases included COVID-19. Paul is a member of the AMA Queensland Council, a board member and scientific advisory member of the Immunisation Coalition. Welcome, Paul. Next, I have...
Thank you.
No, thanks, Paul. Next, I have Dr. Rama Kandasamy. He's a paediatrician immunisation specialist at the Sydney Children's Hospital Network, senior lecturer at University of Sydney. Particular interest in severe acute respiratory illnesses in children and prevention of them through vaccination. He is active in leading vaccine trials and studies in respiratory illness epidemiology amongst children. Welcome, Rama.
Thanks, Fred.
And we've got apologies. We did have a pharmacist who was going to join us, but she's unfortunately unwell, and maybe that's a reminder that none of us are immune from getting infections. Lastly, Catherine Keel, a nurse practitioner specialising in travel health and immunisations, and is a member of the International Society of Travel Medicine and a fellow of the Faculty of Travel Medicine, Australian. So tonight we aim to finish at 6:45, so it's a 3/4 an hour program. I'd like to acknowledge TSL Seqirus as one of our sponsors, Sanofi as a sponsor, and BioSelect for supporting this educational activity. Now, as people hear anything during the discussions, we'll start with Paul to give us a bit of an update, and then ask Rama and Catherine to talk about what's happening where they are. But if people want to send any questions, we've got a chat room. So people can actually send those questions, and we'll try to keep track of those. And we've got some ideas of where it might go, but we'd love to have material sent to us and questions, and we'll try to answer them. So, and also, if we don't answer them tonight, we will try to get back to you. So leave your details and we'll track. So Paul, maybe we can start with you. If you want to give us a bit of a roundup of what's happening, what we should be thrilled about, and what maybe we can be worried about so far. So maybe Paul, just give us a start.
Yeah, thanks, Rod. Thanks for that kind introduction, and thanks everyone for attending. I'm very privileged to be part of this panel, particularly when you look at the caliber of the other speakers. And gee, it's a tough ask to give an update, because there's just so much happening at the moment. We could spend hours on the update alone. So I guess it's obviously pretty clear to everyone who'll be on this call that there's a lot of things happening right now. So if we start with influenza, interestingly, we had a really sharp takeoff of flu, very similar to last year, some 6 or so weeks ago. It does appear to have plateaued a little bit at the moment. So if we look at our updated case numbers, it's probably the one that's fallen to third in terms of the respiratory viruses being tested. And I guess if I start with the Queensland numbers comparatively, because I know those the best, COVID has certainly accelerated to the front of the race at the moment. So in the last week or so, some 1,400 cases and around 214 people in hospital. Next, RSV with just over 1,000 cases diagnosed and some 70 odd people in hospital in Queensland. I'll come to the national figures in a moment. And as I say, flu's gone down to third. So 40 odd cases in hospital and around 650 cases. So it's interesting that we had a very sharp rise, but a little bit of a plateau with the flu. And I think some people have been falsely reassured by that. I would certainly expect those numbers to continue to climb. And I must admit, I've got to look at the figures to be able to tell you the nationwide figures at the moment. So COVID year to date, 121,000 with 11,000 in the previous reporting fortnight. And this is the more formal report that has a little bit of a lag. So 5th of May. If we look at the flu, 46,000 cases with 6,000 in the previous fortnight, and RSV 60,000 and 10,000 in the previous fortnight. So very significant numbers there. And while, of course, we're focusing on the viral causes, the other thing that's compounded the situation right now is that we're seeing quite high rates of mycoplasma and whooping cough, both in my state here in Queensland, as well as across the country. And I think, there's a number of things to consider with these data. I think, first of all, it highlights the importance of testing, particularly with a PCR in the lab, because we can test for those other things as well. But we also have to keep in our minds the fact that those case numbers are really much less important now than they were at the height of the pandemic, given such low rates of testing. And some of the ways we know there's a lot more activity out there than we're finding is the case positivity rate, so the proportion of our PCR tests that test positive. And for some of these things, it's 10 or 20% at the moment. So mycoplasma, for example, about a quarter of those are positive, but with COVID, that's gone up over 10% again at the moment. So it does really highlight the importance of testing. If we look at rapid antigen tests, obviously we have the combo ones for flu, COVID, and RSV, but we'll miss those bacterial causes. And then I guess in terms of further update, if we look to COVID in particular, a lot of the discussion today has been about the FLIRT mutation and the fact that those case numbers are rising quickly. And so I don't know if now's the best time to go into that level of detail. Rod, pull me up if I waffle on for too long. But the FLIRT terminology relates to a mutation in the spike protein, which isn't new. This is what's caused all the new subvariants that have caused us problems and ultimately been the main cause for all these repeated waves. The actual subvariants are KP2 and KP3. And so it's basically another change in the surface of the virus that's caused this wave at the moment. And so that's where we're up to with COVID. And I can see some questions coming through in the chat, which is the next point, which is some news just through this afternoon on two fronts. There's been some detections of avian influenza in birds in Victoria, and actually a human case as well in a return traveller. Now, fortunately, and while details are still emerging, I understand that the young patient who's tested positive has done well and recovered. It's a little bit of a historic notification. And my understanding with the avian case is that we still don't know that it's the exact same one that's causing all the problems, particularly in the US, as well as elsewhere in the world. So that testing to confirm that will happen. But we know that this was going to happen. Some suggested it might happen later in the year when the migratory birds return. But there's been a lot of recent detections, even in Antarctica, meaning that this is obviously spreading quite quickly. And so, some of the questions I think are coming through about how concerned we are. And I think it's certainly not time to panic, of course, but I think it highlights what many of us have been saying for a long time about maintaining a certain level of preparedness, maintaining basic activities like surveillance so that we're ready if or perhaps when this was to become more of a problem. And fortunately, we're in a much better position than we've ever been in some ways in terms of our ability to respond to a new influenza situation. But then having said that, some of our challenges, including things like misinformation and I guess fatigue, etc., might mean we'll have some challenges if we were to try and put out some notifications now about this. We might face some opposition. People are already asking about vaccines, and again, Rod, slow me down if I should come back to this later.
I was just going to maybe flick over to Rama, because the traditional story is that RSV is what puts children in hospital. So maybe Rama, you could just give us a bit of your perspective on RSV and some of the questions, which I think is slightly misunderstanding, but just saying, is there only RSV vaccines? And I think there's a misunderstanding about the monoclonal antibodies and the vaccines that are available, what's been registered, what's actually available, and what's coming through the pipeline. So Rama, did you want to just pick up from your perspective?
Yeah, sure. So I suppose from my perspective, which is being a paediatrician and immunisation specialist based in Sydney and New South Wales, in particular at the Westmead Children's Hospital, it's very much true that there's plenty of RSV, particularly this time of year, and particularly over this kind of probably month and a half, 2 months. It's been increasing and starting to see a decline of more recent weeks, but just in the Children's Hospital I work at, probably at peak we were seeing probably 30 to 40, RSV positive cases presenting into ED per day. And obviously a fraction of those being admitted into hospital. So yeah, it has a high hospitalisation rate, particularly in young children, particularly those that are under 6 months of age. And so yes, Rod, it does put kids in hospital. I think kind of segueing into kind of the immunisation around RSV. Essentially, for children, there is a passive passive immunization, so a monoclonal immunoglobulin, which has become available in a few states for this coming season. There is also a maternal immunisation, which isn't available at the moment, but is going through kind of the regulatory process and is being used obviously in other regions around the world. So those are the two, I suppose, approaches for children. There is RSV vaccines for older adults, and that's definitely not my scope, being a paediatrician. But those are being used, and it's definitely one available in the community, at least in most jurisdictions now, for older adults. And RSV is definitely a problem in older adults as well. And so it's those two ends of the age spectra that are particularly affected by it. I might just
Rama,
turn it over to you.
Yeah, Rama, you mentioned that the monoclonal antibody is available. So there's been a monoclonal antibody available for at-risk children for a while, but it's only been lasting a month, whereas the new ones that are available in Queensland, Western Australia and New South Wales, but that's got its own issues, and we'll talk about that later maybe. But the three states, they're offering the new ones, which is giving us a year, I understand. Can you just update on that?
Yeah, look, the duration of I suppose coverage from the new monoclonal antibody against RSVs is from the studies, more out to 6 months, I would say. We don't have data that would indicate good coverage beyond that period. But if you use that back to importantly around the time that you might be seeing, or just before you see kind of peak of RSV disease in the community, then and also early in life, which is the period where you're most at risk of ending up in hospital with severe RSV, then you provide good efficacy in terms of preventing hospitalisation in kind of those younger children.
Yeah, so I'll come to you, Catherine, with what you're seeing, but I have noticed mycoplasma. So the atypical pneumonias have surprised me but I think Paul's made the point that we should be testing. So we'll talk about that later and maybe talk about some of the treatments for mycoplasma and the atypical pneumonias. But that I think tells to me we should be testing so we know what's around. But before we get to there, Catherine, do you want to talk about what you're doing, what you're seeing, and what sort of noises you're getting back where you're working?
Yeah, sure. So I'm a nurse practitioner. I work in the community in primary health, so I give the vaccines. I work in rural South Australia. So I've definitely seen an increase in children and under 5 vaccine uptake. It's still lower, definitely from previous years, definitely from pre-COVID. And it's really the families who come in, every year to get vaccinated. But in the last few weeks, we have been giving more vaccinations. Lots of talk about RSV with the older adults as well. The issue with that is the cost of the vaccine, which is retailing around $300. I have given some, not many, and it's just the cost is the issue really. I would like to just take the opportunity when we're working in primary health that we just make sure all the NIP vaccines are up to date, all the pneumonias and so forth. And like Paul mentioned, we're really concerned about pertussis. So it's normally a private vaccine for not for older adults. Obviously, pregnant, it's funded. So just to talk about that as well. So just taking every opportunity to talk about vaccines and answer any questions.
So maybe we can go to the mycoplasma. So there's some interesting questions about that, Paul. We talked about that when we were looking at our individual cases and what was the right treatment for it. And I guess it is a bacteria that is sensitive. But do you want to talk about what broadly is the treatment?
Yeah, absolutely. I mean, it's an interesting phenomenon we're seeing with mycoplasma at the moment, and a lot of people are debating as to why we're seeing such a high burden of that. And there's probably a multitude of reasons. I mean, a little bit like even things like pertussis, it'll fluctuate every few years, and some say 3 to 5 years. I don't know it's quite as predictable as that, but we'll see a rise for a variety of reasons. And then, of course, we change the pattern of transmission of every infection almost, but certainly every respiratory infection by our COVID mitigating strategies, of which, of course, there's now essentially zero. So, it's really clear we're seeing a lot of mycoplasma and anecdotally some more severe cases. We've looked after a few in ICU, which I don't recall ever doing in my entire career. And my wife's actually unwell with mycoplasma at the moment. So we've had some firsthand experience. And coming back to the treatment, a lot of guidelines would suggest doxycycline as the primary treatment, depending a bit on where those guidelines are from. So I believe it's 100 milligrams twice a day for 7 days, but of course, consult relevant local guidelines. And then obviously macrolides, so particularly azithromycin or clarithromycin, depending a little bit on your experience. Some of the challenges there were around some macrolide resistance, potentially in Asia earlier on. I don't think we've had that confirmed as an issue here. So, as I say, it's probably clarithromycin, azithromycin if they're more unwell, or doxycycline are probably the main things we'd go for. But, as we've said a few times now, getting tested, getting the right diagnosis and starting treatment as quickly as you can in those that require it is the key there.
So, Catherine, I would just ask you a question about something that's coming up, about whether there's actually vaccine resistance or whether you think it might be more hesitancy because the numbers seem to be lower. And then, Rama, I'll ask you to just maybe go through the difference between the vaccines we got available, so the ones in the pipeline are going to be adults, maybe the pregnancy. And even though the media is talking about vaccines for children, they're not actually vaccinations, but it's being often reported as vaccination. So maybe, Rama, after Catherine's spoken, you can just go through exactly what is available for children and what the philosophy is for treating them. So, Catherine, is there resistance? Is there pushback? Is there now, 20% anti-vaxxers? Is that what you're seeing?
Can't use anti-vaxxers. No, vaccine hesitancy. Definitely vaccine fatigue post-COVID, without a doubt. I do think there is more vaccine hesitant, especially parents with their children. I think the rollout, the COVID vaccinations has caused that, especially with all the media reports. They're concerned about the vaccines and so forth. So we're having more discussions about the children getting flu vaccinations. They want to know all the details, whereas previously they were quite happy and they didn't really ask too many questions. So I would definitely think that we're getting more vaccine hesitancy in the community.
You're getting people asking for specific vaccines, because remember we started to get everyone with which COVID vaccine they wanted. Any comments about that and any thoughts on that?
I would say, and rightly so, people are more clued up about vaccines post-COVID. They know all the different vaccinations. They can reel off lots of scientific data, whereas pre-COVID they wouldn't. So they want specific, obviously, specific flu vaccinations. They want to know what's in the vaccinations, what kind of vaccine they are, which pre-COVID we didn't really get too many questions like that. So it's important. It's important to educate our patients. So it's important to answer those questions, give them resources, evidence-based resources to go and look up, so they're comfortable with the vaccines.
So Rama, going back to maybe just go through what's available for vaccines. So there's one TGA approved. There's 2 on the pipeline. The second one, I think the Pfizer one, is I think has been given clearances for pregnancy. And then what's happening in children, because it's different in each state. And then maybe your thoughts on whether it should be available through private script, and what do you understand is happening with that. So there's sort of 3 or 4 broad questions, Rama.
Yeah, sure. First of all, probably start with the children, the pediatric context, and so the approach to protecting children against RSV through immunisation is largely through essentially giving them an antibody, and so there's one approach which is giving the antibody, the monoclonal antibody, as we mentioned, as a baby, to protect them, largely through that first 6 months of life, which is when we see the highest hospitalisation rate, and obviously it's usually the first time you encounter RSV as a child is generally in that first year of life, for that matter. The other approach is immunising the mother while she's pregnant, so that she passes the antibody that she generates to the RSV vaccine, and so it's an active vaccine in this case. She will generate an antibody and pass it across the placenta to the child, and so they have that antibody in reasonable concentrations when they're born. And so it's still the same approach. It's a passive immunisation approach of the child, but you're actively vaccinating the mother to achieve that. Now, that product that is going through the approval process for pregnant women is also the product that they are using for older adults over 65, essentially to try and protect them against RSV. And there's also essentially a couple other companies who are similarly producing products for that age group, which are active vaccines to protect them against RSV, generally in that over 65 age group. And so that's it I suppose in a nutshell. There is I suppose at least one active vaccine, as you kind of alluded to, available, or at least gone through the regulatory process, so that can be made available for use in the older age group, over 65 adults. And the only product at the moment for children, and this is only in select states at the moment, is the monoclonal antibody, which is given obviously targeted towards babies, generally in those first few months of life.
So some interesting questions have come up. My understanding is that it's not available on the private market because there's limited supply. I've been told that the reason that only 3 states have got it is because it's limited. I know, Paul, you've had a chance to talk to people about its use, and it hasn't been as straightforward as I would have thought, because I would have thought as soon as someone said, "Oh, you've got a prem baby, I can give you RSV to cover this winter," they'd be right into it. But you said it hasn't been quite that straightforward. So do you want to sort of develop that theme a bit? And then, Catherine, I'll talk to you about some of the resources available to help families understand what's happening. So, Paul?
Yeah, look, I think it's a fascinating, almost social science experiment what's playing out here. I mean, we know that there's challenges with confidence and trust in public health and vaccines in general. And, obviously there were some external pressures on, different states funding this differently and supply being put aside for the states that expressed an interest early. And whenever we have a disparity in guidelines or availability, I think it also raises people's skepticism about why one state's using it and one's not. So the equity, I think, is really important. And we have found ourselves in a situation where some states have it available and some don't. And I think for a variety of reasons, there was some urgency around the approval and implementation, obviously given it needs to be given ahead of the season, for example. And you'd be surprised to hear that things were left to the last minute to roll it out. So all of a sudden we had an announcement almost overnight that every baby's going to be receiving this new injection, and there was no prior information made available or discussions or education. And to be honest, a lot of people that were prescribing and even administering this didn't know that it was actually happening until the day they were told to do it. So of course there was some challenges in that setting, and not everyone was accepting of that. And some discussions we've had recently, it's fascinating with our routine childhood vaccines. Our uptake has actually been traditionally very good in this country, but now we're actually introducing something new to that, what the perception will be. And I think most people, I haven't got data on this yet, of course, but most people are quite accepting. But there have been some people who have just wanted to get more information or wait and see, for example, or not be first cab off the rank. And so it's been a little bit more challenging than maybe people first anticipated.
Yeah, and it's come up when we were at a meeting yesterday talking about making new vaccines. But if we don't get the consumer involved and don't get the people who are going to receive these vaccines on site early, we can make these beautiful vaccines that in our mind are the best thing since sliced bread. And then when we offer it to our patients, they say, really, I'm not sure I want it.
Yeah, look, I think it's an excellent point. And, we need to do more to educate around these things, and both the consumers, patients, our people in the population, but also our prescribers. So we're all on the same page, and we know exactly what we're doing, and we're all consistent. And so, vaccination has become incredibly challenging. It's evolved more quickly than we've ever seen. And as we're talking about RSV vaccines, this has been something we've been trying to crack for 60 years. And all of a sudden we've got, 3 new options realistically. We've got a number of COVID options. That's going to be updated. So it's complex, and we need to be prepared for those difficult discussions, make sure we're armed with information and be proactive. I think, it's really clear that the more we speak to people about this and give them the chance to have their concerns addressed, the more likely we are of having reasonable uptake.
So, Catherine, what do you have under your arm? What's in your pile of tricks to help educate people when they appropriately are asking these questions?
So the resources, I would totally agree with what Paul said. We have to obviously educate the consumer, also educate healthcare professionals. As we know, especially as seen in COVID, target updates are regular. We need to be on top of them. We need to know what the recommendations are. And it's a challenging field. It's what I specialize in. And if you're a practice nurse or, a GP, to read everything that is coming through, it's hard. So webinars like this are very important. So my gold standard is always the Australian Immunisation Handbook. I often open it up, show patients that we read through it. I print things off from it. It's a invaluable resource for anybody in immunisations. It's really important. There's obviously various different other information. We can go into a TARGI, which sometimes is a little bit confusing for health professionals, never mind consumers. NCIRS is really important as well. So I think it's important when you have the parent, the consumer, the patient in front of you, you just don't tell them the resource, but you actually open it, you print things off, you highlight things for them. So it makes it easier for them to understand. So it's just time to educate.
So Rama, pediatrics is important. Everyone's vaccinated. We think the rates are lower. So do you find there's any healthcare professional hesitancy or reluctance to vaccinate? So in your hospital, would you expect 90% of everyone who's seeing patients is actually vaccinated? And any comment on healthcare provider vaccination rates and maybe the population vaccination rates for under 5s?
Yeah, look, I think in general, healthcare providers are usually quite well covered when it comes to their vaccination rates, and probably definitely are covered at a higher rate than the general population. If you had kind of comparative age comparisons. So yes, I think there's kind of personal kind of onboarding and belief, and adoption. I think though generally when you talk about pediatric populations, again, coverage is generally good, although we've obviously been seeing ever so slight gradual drop off each year since the COVID pandemic, I would say. That is kind of multifactorial. I think when it comes to kind of your routine vaccines, I think obviously there's there's a growing number of vaccines in the schedule, so there's a growing needle burden, and there's challenges around that. Obviously, as we've kind of touched on, there's growing literacy amongst parents and carers, and so I think part of it might reflect that. And also, other, there's multiple other factors, that we can touch on that might affect one particular person, such as mandates and all the other things that are affecting, people leading up to them getting vaccinated. I think, particularly with something like flu coverage amongst children, where the flu vaccine, at least in New South Wales, is funded for all children under 5 years of age, and we have quite a low coverage rate, which is in around 10 to 15%. And that's not just this year; that's probably been most years. We had a bit of an upspike that year around the first kind of COVID pandemic year, because there was a bit of motivation not to get unwell with the flu, to kind of end up in hospital and take up hospital beds and things like that. But yeah, we're seeing quite low coverage rates for flu, which is delivered in a seasonal fashion. And I think everyone's very much aware that flu comes around every year, and the vaccine's available every year. But I think one criticism is it's not well weaved into the routine childhood checks. And so getting a child in to see a doctor who's otherwise well and have a vaccine has been a challenge. And is kind of not, I suppose, integrated into kind of the routine kind of operations of any kind of family units. And so that's, one clear barrier. I think, within a busy family, I think layer on top of that, the busyness of the schedule at the moment, and you see people start to, become a little bit hesitant or just not as engaged with getting their kid to the doctor to have a vaccine. And so I think we have to think a little bit laterally about how we solve that issue. Is it that we continue to largely deliver things like flu vaccines primarily through the primary healthcare deliverer, or do we have to take other approaches? And obviously the pharmacies have been involved in trying to break down some of those barriers, but do we have to think even beyond that to some extent? I think the other part of it is also just trying to plant the seed before you even get to the doctor, and so or the nurse or the pharmacist. I think if you're having the first conversation and the first time anyone's heard about RSV there in the clinic, it's very challenging to end up having them leave your clinic with a vaccine in their arm. And so I think those are some of the elements we have to consider.
So on that, the barriers, the childhood vaccination rates have been 90%. We're concerned about where measles are going, with a bit of a drop off, but not below 90 yet. So we've now put flu on the free list. We've now got it part of the schedule, but it still isn't going into arms. So the traditional barriers. Catherine, I'm just thinking, one of the things you mentioned is by having nurses who can give vaccines, it provides extra hands who can do it. And the pharmacists certainly provide after hours, or potentially provide after hours access. So it's a shame we don't have someone who can talk about that tonight, but that's one of the advantages. But we still got 90% of the other vaccines without having pharmacists. So what's happening now, do you think?
I think we've got to look out the box, and we've got to use all healthcare professionals, if it's councils, pharmacists, primary health, any opportunity, paediatricians, any opportunity to discuss and administer vaccines. I think we need to use nurses more and get them to work to their scope of practice. Going to get political now, but it's obviously to do with funding. Why can't there be nurse-led clinics in primary health? Why do they have to go via doctors to get a flu vaccine? Obviously, I'm a nurse practitioner, so I can claim Medicare. And just to free up your GP appointments, everybody's busy. Appointments are sometimes a little bit expensive for GPs. So we just need to use our nurses who are so highly trained in this area. I just feel really strongly we don't utilise them as well as we could.
So someone's made the comment that some specialists are saying it's a 50-50 improvement by having a booster. I would have a view that you always get a benefit. It's just a question how much and is it clinically significant? And then there's also the issue of whether we give vaccines too early. So I think on both of those occasions, I don't have a problem with it. But Paul, did you want to maybe talk about if the nephrologist says it's a 50-50? I still think that's better than nothing. But your comments and also about can we give a vaccine too early?
Yeah, look, I would think it's not 50-50. I would think the benefit's probably clearer. And, one of the things that's been talked about so much is the limitations of COVID vaccines. And, there's obviously a lot of legitimate discussion around that. They don't prevent 100% of infection and, they don't last as long as we'd like, of course. But, someone who's recently boosted in accordance with guidelines is certainly protected well against COVID that's going around. And with the numbers we're seeing, the repeated waves, etc., it remains a really important tool. And, I think we just need people to be aware of what's happening with vaccines. Of course, XBB 1.5 booster released late last year. WHO and April have recommended a change again. And, we need to start, I guess, preparing people for the fact that given the virus changes, our response is going to change so that there's not a big surprise and a lot of complaints when we change that vaccine again in a few months. And, it's such a difficult time because we've got a proportion of the population that are already complaining that why don't we have the new one? I want it today. And then a proportion of the population that are saying, why are we even bothering talking about these vaccines? They do nothing. And so, it's a very polarizing discussion at the moment. And that's where, the more reputable information we can provide, the better, I think. And I still think there's tremendous value in using these vaccines in accordance with the current recommendations.
And the WHO review of giving a vaccine early said there might be technically a drop-off in the protection, but it's not a significant drop-off. So you might drop from 80 to 75% protection, but you certainly get some benefit. But someone raised the possibility of having a vaccine combined. So maybe to you, Catherine, if you had a flu and a COVID vaccine, do you reckon you'd be able to get more COVID vaccines into the arm? I've got an opinion on the fact I'm not sure there's a place for it, but did you want to comment on your thoughts on that?
Are you, sorry, I understood, are you saying that we can give the vaccines together if we give more
there's two
COVID
questions.
flu?
Well, there is one, you can give them together, but two, if it was a combined one, do you think that would make a difference?
Yes, definitely. Less needles. People don't like needles, if there's a combined one, without a doubt. We obviously at the moment we haven't got that privilege to do that. So we obviously, when we're giving flu vaccinations for the recommended groups, we should obviously be offering a COVID as well, which is is what I do regularly, one in each arm. So yes, if going back to your other point, if there's one vaccine, one less needle, I'd be happier patients.
I'd have some concerns at thinking that you might need to change. Paul, you might need to keep them updated, and if you've got a combined one, you might end up being a year behind. So Paul, and then I'll go to Rama about any vaccine hesitancy with number of needles. That's been a challenge for paediatricians for a while. So Paul?
Yeah, just an update, I guess, with the combined vaccines. I've been involved in some of the clinical trials, a few of these combinations, and they're progressing well. So there'll be a number of combinations probably released in the US end of this year, start of next year. Might be available for our next flu season, but realistically maybe the season after. And so, yeah, flu and COVID, and then probably the year after flu, COVID, RSV. And great in terms of needle burden, great in terms of piggybacking on the sort of routine of getting a flu vaccine every year, like a lot of people have fallen into, but the other ones not yet. But some of the challenges are the different seasonality of all of those infections. And so when would be the best time to give it? And so it'll be a balance between that opportunism of just doing it whenever versus giving it at the optimum time. So yeah, they will come. And as I say, probably early next year.
Rama, do you still have any multi-needle phobias, or all the 7-in-1s have fixed that?
No, it's still the first thing often that in my clinic that parents will look at and count how many needles is that, and for particularly at 1 year of age, you've got kind of 3 there on the national immunisation program. Plus, a lot of kids will have a dose of Bexero, so that makes it 4. Plus a dose of flu, that makes it 5. Straight away the parents are like, oh no, let's do the flu some other time, and you've lost your opportunity. And so it's a real problem. There's it's only becoming busier, obviously, with additional product. You're seeing a RSV immunization and potentially, some other products about to be added into the program. Then it becomes, quite busy.
So combined vaccines might make a difference, but it's just been put to me, we still haven't told or come to a conclusion as to why do we think flu vaccination rates are down. So we've got 5 minutes to go. So maybe anything else you want to comment on, Rama, while you've got the floor, and what do you think is the reason why flu vaccines are down? But anything else you might want to add? Fantastic questions. It's great to see what's going on. We will get to answer them because we'll have details when this is being recorded, so we'll be able to get some answers, so we'll get a chance. But anything you want to add, or what do you think the reason for childhood vaccine rates being low?
Look, Rod, I think at least around flu, particularly, it's kind of those things I've already kind of touched on, and so I think one, people are very much aware flu comes around every year, and it's an issue, and potentially their child ends up in hospital, and we had a pretty standard and reasonable flu season last year, and I think there was even a fair amount of media coverage around some of the pediatric cases and some quite unwell children who had flu kind of infection complications. So I think there's awareness. I think there's some general kind of barriers from both sides, both from kind of, I suppose, how the program's largely deployed in medical settings, and then also from the parents and how we have kind of our healthcare child checks structured, and I think essentially for the first year of life, or even up to 18 months, we have quite regular checks, and there's lots of opportunities to get a flu vaccine into those children, and generally we're better in that age group than we are for the other children beyond that age who have relatively little contact with their GP, and tend to not have that kind of opportunistic circumstance to get a vaccine into them. So I think it's that. I think those are some of the factors. Like I said, needle burden, definitely I've seen that personally. And flu is kind of the first one to drop off. People obviously I want to be up to date on my registry, and I want to be making sure my kid can still go to daycare and all those other things, and so they have to prioritize. And that's also a factor. I think that's there. I think convenience is there. We've tried to break down some of those barriers around convenience, but ultimately it's still tricky. We have to think about how we can kind of bring the vaccine to the child rather than bring the child to the vaccine, perhaps. And so starting to break down some of those barriers, physical boundaries, really around it would also.
So, Catherine, we've got a couple of minutes, so maybe ask you what your sort of thoughts as to why it's down. But just to answer the Shingrix and flu, and you might want to comment or Paul afterwards, but you can give them together, so don't better have them in the arms and sitting on the give them together. But any other comments as to why childhood, and then I'll finish with Paul, and then we'll wrap up. So, Catherine.
Exactly what Rama said. I don't think we've had a adequate media campaign advising about the flu vaccine this year. We've had a few states, adverts on Facebook and so forth, SA Health, but not a federal media campaign on TV. I think we need to have accessible appointments that are free. Like Rama said, we've got to think out the box. We've got to do Saturday morning clinics. We've got to do late night clinics. Parents are busy and so forth. And use all our healthcare professionals. So really open up the appointments and accessibility and education, and just be aware parents are hesitant and vaccine fatigue. So we've really got to promote that flu.
Thanks. And Paul, do you want to wrap up with anything specific or something in general? But thank you.
Just to reiterate what the other speakers have just said there, it's a complex situation with vaccines, but we just need to keep plugging away, highlighting the importance of vaccines. But I think the other side of it with flu is people's perception of the risk has declined, of course, given we've been so overwhelmed with COVID communication that they kind of have forgotten that the flu is nasty and makes people sick and puts them in hospital. So it's also education about the significance of these vaccine preventable diseases, because we know it's people's perception of risk that changes their behaviour, that makes them want to do something to prevent it. And so it's about that education too. And I completely agree. We need broad programs to try and get that message out there as well.
Well, thank you. I think tonight's been a useful contributor. Thanks for everyone for asking the questions. We'll follow up with things that we don't feel we've answered during the night. Thank you to all the panel members. I appreciate your input. Thank you to our audience. Your attendance is really important. It's also useful if you can give us some feedback, what you liked and what you didn't like and how we can improve it. The next meeting we've got, this series of 3, is the 19th of June. That'll be the final one of the 3 that we're doing. Please give your feedback. There's a post-webinar survey. You'll get that automatically for being involved. But thank you to our panel. Thank you to everyone who came. Thank you for the opportunity to talk about it. And we look forward to catching up with you and seeing what's going on when we reflect on why the hesitancy at our next meeting on the 19th of June. Thank you, everyone. Have a good night.
Thank you.
Thank you. Thanks, everyone.